So, Ricardo, back to you. And of course, you can imagine you've been amazing in regard to all of your career, the connectivity with the oncologist and try to kind of build the relationships. If anything, TACE plus, as you said, and you were the first to do the space study with the sorafenib, didn't work. And you remember in the beginning we spoke about that we're going to hold that thought in regard to what to combine the TACE with. So tell us about the checkpoint inhibitors, your thoughts.
Well, I mean, as I said, there are several studies that essentially are exploring different combinations using different local regional therapies, particularly TACE, but also Y90 radioembolization. And then with either concurrent or sequential use of checkpoint inhibitors, plus minus additional drugs such as VEGF inhibitors. In particular, there is one phase 3 study that has already been started. So it's the first phase 3 investigating in particular for patients intermediate stage HCC, so those who are currently candidates for TACE. TACE is the standard of care for this patient population. So the study will have TACE and placebo, TACE plus durvalumab, and TACE plus durvalumab, and followed by bevacizumab. So we will have an understanding, I think, in terms of how we can truly jump to a brand new level in terms of survival, because this, unfortunately, has not been the case. As I said before, despite all this technological improvement and the ability to do better and better TACE, but then the bottom line in terms of survival has remained relatively, unchanged over the years. Yes, there has been an improvement, but we aim for more.
Fair enough. So if anything, this is really what Ricardo just said is very critical, because if anything, we did realize that, and we did prove that TACE plus a TKI did not work. On the other hand, a TACE plus checkpoint inhibitors is being worked up, and we're trying to see. But I like very much the idea that Ricardo just brought up about actually TACE plus a checkpoint inhibitor plus also an anti-angiogenic, which is the Durva plus Bev plus TACE, which, if anything, the Emerald-2 actually is going to be very intriguing. And this really brings us to a point which is quite critical, is are all the TKIs quote-unquote being understood as being also anti-VEGF, or is it really there's certain particularity about the BEV, like the BEV Turva plus TACE, that really bring it or give it a little bit of a more advantage? This is time will tell. We just have to wait and see. With this said, I would like to go back to another point by everybody, and I will ask Mike, and please, just one sentence so we can wrap it up. And I will just pick up the subject with you of your choice of TKIs in second line. One sentence.
It's good to have choice, and that's what I present to patients. There are choices.
Fair enough. I totally agree. And it's good that we have that many choices. I would say that the conditional two things of the Rigo with prior sorafenib and the Rami with the AFP kind of interestingly give a little bit of an open highway for the cabo anyway. For you, Catherine, the question is in regard to the checkpoint inhibitors and what do we need to understand about the immunity of the liver to begin with? PD-L1 or combination with CTLA-4?
I think that we're going to end up with combination as the best response, but we also need to protect the liver during all of this. And I think the most important thing, again, taking it back to the multidisciplinary tumor board and make sure that the patient's liver function stays good enough to have access to all the different lines of therapy that we have.
Absolutely, and that's really what is quite intriguing, and we just have to wait until we see more of the data of the Nivo versus sorafenib, as well as wait for the critical data that we will get on the Durva plus Trami. Tim, adjuvant therapy, I didn't ask about that yet. One sentence about the prospect in regard to adjuvant checkpoint inhibitor.
Well, again, as I said, I think it's a very interesting approach. Obviously, we will get to answer all the other questions you had just asked way earlier, and it will take just some time to figure this out. But I'm looking very much forward to those data.
Absolutely. And lastly, Ricardo, I will ask you, tell us one more time, I'd love to hear it from you, TACE plus the Durva plus Bev, your thoughts.
Well, my thoughts, I mean, if I can say something more general at this point, I think for hepatocellular carcinoma, clearly having multiple options is extremely important. And we have seen progress with this. Let's say in the past, for early tumors, everybody was going to resection, and resection didn't really have outstanding outcomes. With the advent of interventional therapies, then patients were better selected. And this is, I think, a major improvement. Now, I see something similar, for instance, in the intermediate stage, where because of the availability of effective drug, effective systemic drug, we can better select patients who will go towards the TACE.
I absolutely agree. I totally agree with you on that. And this is, if anything, quite intriguing. But I agree with you. Like, we just have to wait for the Durva plus Bev plus TACE data. With this said, amazing, I'll tell you. Thanks, you guys, for being here. So thank you all for your contributions, this discussion. On behalf of our panel, we thank you for joining us, and we hope to find you at this peer exchange discussion to be useful and informative. I wish you a great day. Thank you very much.